Would you, please remind
Yes, absolutely. We want to see you in either February or May.
Right now.
Okay.
My husband and I are moving every 4 months.
if you will, we need you logged into your laptop, listening and making sure it's picking up the audio and that everything looks good as well. So if you could have yours right here and all.
And I'll remind if they have a question, wait for Sunshine tonight.
So that people can hear that. It's really important that if they don't talk, if they're not listening as well. So that
Okay.
the two of them are okay.
Yes.
So that they can hear
They just put together. They're not really co-owners. Yeah. And there's a number of organizations throughout Oregon.
Utah.
How are you guys? It's great to see that you're like so live, but it's still 10:30. So thank you for coming to our first breakout session. So this is our finance session. So my name is Jennifer Dahl. I am the current finance programs chair. And so we have several sessions over the next 2 days for you guys that are breakout sessions for finance. And so hopefully you will enjoy them as we look at things that are looking outside of claims processing and the patient account side, and getting some topics for you that are more the general finance. So we're excited to have all of you here. It's really a great room. So we're going to start our first session on the value-based care in provider organizations. So we have 2 individuals here for you today from 2 provider organizations. And so we've got Providence and OHSU that are going to talk about kind of what they have going that's in the value-based care and the kind of the risk-based payment model. And so that will give you a perspective of what those 2 organizations are doing. And so we're going to start out with Sophia Gilman. So I'm going to read a little bit of a bio about both of our speakers, and then Sophia will get started. So Sophia Gilman is joining us from Providence St. Joseph Health. She came down this morning from Seattle, so she had a super early flight. So thank you for being here. So she is the Director of Value-Based Care. She has nearly a decade of healthcare experience and leads the Value-Based Care account management team at Providence. And she supports the value-based care contract implementation and performance across all of the Providence locations within the regions. So prior to this role, she was at Providence, Alaska, leading the region in collaboration efforts and with physician groups. So we thank Sophia for being here. After Sophia finishes, we have one of our providers from OHSU here. So we have Dr. Johanna Warren will be speaking about the process within OHSU. So Dr. Warren is an associate professor of family medicine and division head of primary care division within OHSU. So we are excited to have physicians here. It's kind of part of our triad is that we try to have providers and physicians and payers at our conference. And so we're excited to have physician representation. So thank you, Dr. Warren, for being here. So she serves on several different councils and committees within primary care, and she's helping to develop and implement population health strategies and tactics, and she's begun to create a consistent care delivery model across the primary care practices. So OHSU has nearly 300 clinicians and 300,000 visits within the Portland area clinics. And so there's a lot going on. And so I'll give you kind of a perspective of a larger provider and kind of how they're working in that value-based care atmosphere. So thank you both for being here, and we'll let Sophia get started. So, a couple of things to remember as Sophia comes up is that if you do have a question, Sunshine and Sunshine's in the back of the room, we will both be in the back of the room, and we'll run up and provide you with a microphone. We do have some of our members that are viewing online, so in order for them to hear your questions, we would like to do it with the microphones. And so if you have questions, just give us a minute and we'll catch up to you. And then we'll try to also rephrase the question if we need to.
Thank you, Jennifer. Hi, everyone. My name is Sophia Gilman. I work for Private Teachers of Health. And can we get some sense of who we have in the audience? How many of you are clinicians? Two, including our speaker. Great. How many of you are healthcare finance professionals? Great. What about care contracting? Nice. What about contract implementation and performance management? All right, so thank you so much. Full disclosure, I do not work in finance, but I have, even though I'm listed on the financial session. But I'm hopeful that the information that I'm about to share with you will be helpful to you when it comes to understanding some of the challenges and complexities of managing value-based care contract portfolio, which in turn may prove helpful to you and may inform you what in that space as well. So for those of you who are not familiar with Providence Institute of Health, we are with a large organization. We have more than 50 hospitals, more than 800 clinics and we employ about 55,000 physicians and nearly 40,000 nurses. And we operate in 7 states, all throughout the West Coast, and as well as Texas and New Mexico. Alaska there, the region where I started my journey with Providence, a region very dear to my heart, so I want to call it out. Largest region geographically, but very small regions population-wise. So within Providence Institute of Health, we have a population health management division, which was created about 4 years ago to really focus organization's efforts on population health management and really ensure better outcomes for populations that we serve in our diverse communities. And within population health management, we have subdivisions, or should I say, different teams, including care contracting, enterprise care management, value-based care. That's where my team is at Providence Health Plan, as well as IU Health Solutions. And I don't expect you to read all of that, but it's just a quick summary of what each of the divisions does. And value-based care team, that's my team. I'm a part of that team. Is the team that oversees the organization's performance for more than 150 million lives in our discovery regions throughout different regions. And we support implementation and performance of those contracts, and with information and data and different tools that we develop for our regions and service areas and clinics to really help our providers to succeed in value-based care arrangements that they are in. So what is value-based care? I know we in the industry talk a lot about that, and but I thought it may be helpful to kind of have value-based care one-on-one for those of you who don't necessarily directly touch value-based care arrangements, but when you work, it's hard to work in healthcare these days and not to be involved with value-based care work in some shape or form. So healthcare, where has been fee-for-service infrastructure, fee-for-service models is something that we're all familiar with, where compensation to providers is really tied to the volume of care and services that is provided. And there's some very known downside of that payment model, including potential for overuse of certain services and potentially reduced focus on preventive care. And where is value-based care going? And that's where is healthcare going? Hopefully value-based care. And that is the reimbursement methodology that shifts the focus from increasing the volume of services to providing high quality, cost effective, efficient care across the care continuum, and which is achieved through aligning provider and payer incentives, which is achieved through rethinking how we deliver care, putting more focus on preventive care, utilization management, care management, and changing provider behaviors. So there are very many different value-based care arrangements, different types of value-based care arrangements. And to talk about the spectrum of value-based care arrangements, I'm going to be using HCP-LAN APM framework. Are all of you familiar with HCP-LAN? Some of you are nodding, some of you are not. So HCP-LAN, which stands for Healthcare Payment, Learning and Action Collaborative. It's a public-private partnership that was established, I think around 2015, with the goal to accelerate the transition from fee-for-service to value-based care. And APM framework, alternative payment model framework, is one of the contributions of HCP-LAN framework into the process. So APM framework is basically, well, it started as a classification system for different value-based care arrangements that currently exist in healthcare, currently exist in the industry. And whereas it started as a classification system, it has become sort of foundation for implementing APMs in different organizations throughout the industry, and it has become a common language, common vocabulary in the industry. So you probably have seen already the use of this terminology, and if you have not yet, I expect that you will in the near future. So here's the basically APM framework at a glance. So the framework categorizes value-based care arrangements in, well, essentially 4 categories, with the first category being the fee-for-service payment models, such as your basic fee-for-service. You come, we're all familiar with that. You come to the doctor, you get care, and somebody hopefully pays. Categories 2 APMs, they are Category 2 APMs are your fee-for-service payments subsequently adjusted for your as a provider work around improving quality of care. And those are your pay-for-reporting arrangements, your pay-for performance arrangements, quality incentives and quality bonuses of different kinds. So still in this category, you don't see downside risk. It's an additional payment for additional work that you do, mostly around quality. So if we move to category 3 APMs, these APMs still built on fee-for-service infrastructure, but the payments are tied, the incentive payments are tied to providers' performance on cost and quality. And that's where you can start seeing, well, you actually, in this category, you start seeing downside risk. So a good example of category 3 APM would be a shared savings arrangement gated on quality, where you need to put a lot of focus into utilization management to reduce the cost of care. And at the same time, you need to demonstrate that quality is also improving as you do that, that you're not reducing the care provided to your patients. So, and shared savings can be with downside risk as well as just upside on the models. And then category 4 payments, APMs, these are a lot of, there would be your prospective population-based payments, and epidemic models would be a good example of that. For example, global capitation arrangement that a provider may have with a payer for sort of membership. So private St. Joseph Health portfolio includes all 4 categories of APMs, and that, as I mentioned earlier, around 1.3 million lives that we have in different value-based care arrangements. And once your portfolio has become large, once your portfolio has started growing really fast, there will be some challenges, some complexity of managing the portfolio that I think any provider would face. And just to name a few challenges, some of the complexities of value-based care portfolio management is, first of all, it's, well, contracts themselves, the contract structures grow in complexity. The targets have become more and more difficult to achieve, and that's both cost and quality targets. It's no longer enough to just aspire to do better. You actually do better. You know, you have stretch targets every year, and you have to have those targets because industry, industry, other providers in this industry, they're also doing this work. So just because you are better than where you were 2 years ago doesn't mean that you are in the top, quartile in the industry, because everybody is working in this space. There are some challenges, some complexities around variability of membership in your contracts, because before you start, before you attempt to manage a population in a particular value-based contract, you really need to first know who is your membership, who are the members in the contract, and depending on how methodology what methodology is chosen for designating population for your this contract. There may be certain nuances of how you may want to approach managing that population. The variability of quality metrics and targets across the portfolio, and I'll touch on that a little later on. Variability of performance and reporting cycles across the contracts. A lot of contracts we see, they're around January to December. There's some contracts July to June. I've seen contracts June to May or October to September. And just aligning the work across the entire portfolio really needs to take into consideration those nuances. There are some challenges, a lot of actual challenges that have to do with bidirectional data exchange with payers. Many payers have different requirements on how they want to receive data. A provider organization may end up receiving data in many different formats, which requires a lot of work, a lot of time in trying to figure out, trying to extract useful information from all the data. There are some challenges of financial performance evaluation and tracking for contract, particularly it is challenging, it can be challenging to estimate the financial potential of this contract. There's also significant timeline in receiving claims-based performance reports from a payer on how you're doing in this contract. It's not unusual to have a delay of 6 to 12 to 18 months until you know how you did it in a particular performance period. And also there are accounting and budgeting challenges because performance year and reporting year and payment year, when you work in value-based care, often 3 different years. And that is a challenge. So going back to the membership, as I mentioned, before you begin, before you start, before you attempt to manage a population in value-based contract, you really need to understand who your members are. And there are many different ways, well, there are a number of ways in which certain population may be included in your value-based contract. And we often see two methodologies of designating members for a particular risk arrangement. That would be attribute membership and assigned membership. And there are pros and cons to both methodologies. And particular methodology may be chosen based on the line of business, whether it's commercial, Medicare, or Medicaid, may be chosen based on the arrangement structure and other factors as well. So when we talk about attribute membership, that's where members are included in these contracts often based on claims experience. So it could be prospective or retrospective, but essentially if I go see a particular primary care provider, there will be a claim generated for my primary care visit. And based on that claim, I may be included as a patient in value-based care arrangements between that provider and that payer. The good thing about that approach is that I already have a relationship with provider established. There is an EMR record for me. They know how to reach me. They have some of my history, which will make future outreach to me as a patient potentially easier. And when you see attributed membership in a contract, especially when the attribution is done retrospectively, so at the end of the year, of a performance year, attribution attribution process is run, and provider knows who the members in the contracts are. Whereas there are a lot of cons associated with that, so you don't really know throughout the year what's your exact membership. One of the positives of that approach is that providers are encouraged to treat everybody the same way and improve the models of care and quality of care for everybody equally, regardless, in kind of peer agnostic manner. But some significant cons of that approach is that there is a need to maintain accurate provider rosters to make sure that provider does not get members attributed to their risk arrangements inappropriately. This is something that actually my team is working on actually right now, and sometimes it's a monthly process to audit rosters to make sure that you don't get any patients attributed to you through, say, urgent care providers that don't really manage the care of the patient, and they don't have the relationship with the patient to manage the total cost of care of the patient. As I mentioned, patient engagement may be challenging, especially with respect to attribution. And also, just because I went to see the provider once, say 18 months ago, doesn't mean that I'm coming back. So I may be attributed to some providers, but it doesn't always mean that there is a relationship.
How's your team dealing with internal medicine? That's always a fun one to deal with.
Internal, that's a very good question, as well as some specialists. Oh, do you want me to repeat the question?
Sorry.
Sorry to interrupt for that.
How is your team dealing with internal medicine?
So with internal medicine and some specialists, like cardiologists and some rheumatologists that actually can serve as primary care providers in some cases, that's always a tricky one. And in some cases, for attribution methodology, we use a combination of provider information and CPT codes. So the methodology becomes more complex, and it's not something my team would. And a plan would normally do that, but they would use a combination of really CPT codes to make sure that those are appropriate CPT codes. And still, there's always some room for error, but that could be one potential solution to the issue.
So if there's members that come at the end of the measurement period, like say GCOM done, or is there any rule that you follow that if you only came once in the performance period or if you came at the end, you want to count?
So what I've seen happen in some of the arrangements, so if we use attribution, say monthly attribution for members, and so we have performance period, for example, January through December, and I go to the doctor in August, for example, that's my first visit. So what I've seen in some arrangement that my care, once I have that patient relationship established, it would be August on that my care would be attributed to this particular arrangement. Does that make sense?
The measurement period ends in December, so if somebody came in December, the PNPN should be
only for the months that I was attributed to the contract, not necessarily for the whole year. But, it really depends on how the attribution is run. If it's just once a year at the end of the year, you will not necessarily be able to separate the months, for which I was attributed to the contract and which I was not.
I was thinking of the annual. So in the annual, you would count that those members that just came once, right?
No, you would. If it was my only PCP visit, because there's also an issue. What if I go to two different PCP, primary care providers? What if, so if I go to two different ones, what some plans do, they take your most recent PCP visit to see to which provider to attribute you. Or if there are, say, 3 visits with one provider and 2 visits with another provider, they use the provider attributed to the provider with whom I had the most visits. So they're really, and sorry if I'm not giving you the answer you're looking for. It does get quite a bit complex with attribution, and that's why I included this information because this is something everybody should be paying attention to, because depending on, we need to, as providers, need to understand how our membership is, is included in the contract, because that will inform a lot of our decisions how we approach managing those patients.
Basically, the larger question is some members come many times and some come just once.
Right.
But you get the same PNPM for every. So is it just on average level that the PNPM comes out because some only use once and some comes 10?
Oh, I see what you're getting. So when you say PNPM, are you talking about some capitated models?
Yeah.
So for capitated models, attribution probably, they need to be really spelled out, how the attribution process is happening, right? Because if a member is in your panel for which you get a capitated payment, it won't really matter, like you said, how many visits I made to a provider. It will be the same PMPM basically. But actually, when I was talking about the attribute membership, what I had in mind was more shared savings arrangements that have. It's not a capitated payment, but it's an arrangement where provider has an opportunity to share in the savings if the total cost of care is managed really well. All right, so the next one, a few words around the assigned membership, and that's where members are included in the risk contracts prospectively, either based on the member's choice of the provider that we often see in Medicare Advantage programs, or sometimes based on our assignment by plan, and that's not unusual for various Medicaid value-based care arrangements. There are also pros and cons of assigned membership. One of the significant pros is that contract membership is typically more stable compared to attributed membership. And tracking utilization quality performance specific to a contract is typically easier because you know who your members are in advance. You know whom to pull in for your dashboards, for your reports, to track utilization, to track quality improvement. Some of the cons include that members may not be members who may be assigned to may not necessarily be established in the application. And we see a lot of it happening when assignment happens, when it's out-assignment. And that creates a real challenge when it comes to outreach to those members. When we are, as a providers, responsible for the total cost of care for those members, but we have no relationship with that member. And the member may be not seeing any primary care physician, but maybe utilizing emergency department when the conditions that come to emergency department could be treated in a lower acuity setting. And also some, reassigning members to different provider may be difficult. It's something my team also works with. Sometimes we review the membership rosters and make sure that members are attributed to us correctly. Sometimes, one of the recent cases when we did the audit of rosters, we saw that the member was actually who was assigned to a provider in Washington had moved to Oregon, and the plan just did not have that information. So there are different plans have different processes for the assignment membership to away from the original assignment provider, but it's not a fast process. All right, so there are a number of challenges that have to do with how cost targets are set in the contracts. And there are many, many different ways to set cost targets in value-based care arrangement. And here, I'm really, if we go back to the framework, so here I'm really talking about the category 3. Okay, category 3 APMs, where provider incentive is tied to providers' performance on cost. So just to include three different methodologies as examples. So per member per month, PMPM cost comparison to a control group. That's could be this methodology could be used to set a target for a provider in a shared savings arrangement, for example. And there's some also, pros and cons to this arrangement. So one of the downside is that if you're a provider, if you're a unique provider of certain services in the community, if you're the only provider who has certain specialists, you will tend to have more higher cost of care compared to other providers in the community. Control group, which may be providers of similar services in the community, and typically it's pretty defined in detail in your contract. Control group may not be providing the same level of access and healthcare services as you. Sometimes with this, well, actually, most of the time with this methodology, you will not necessarily know your exact cost targets until the performance period is over. So if you are compared, if your performance is compared to the performance of other providers in the region, for example, you will not know exactly what you're against until the year is over, which creates certain difficulties when it comes to managing costs and really understanding what you should be aiming for. Throughout the year, you may be trending really well based on the interim data, but, at the end of the year, you may not be generating any shared savings just because, in the fourth quarter, other providers show some dramatic improvement. PMPM, the second methodology included here, PMPM cost comparison to past performance. So providers, so that methodology gives you a little bit more visibility and control over your costs when your performance in a given performance period is compared to a past performance adjusted for trend, adjusted for risk of the population that you're serving, page allowed ratio, different adjustments that you may see, appropriate for creating the cost target. But one of the significant downsides here is that providers with historically low cost of care will have a more challenging target because there's only so much progress. Once you have improved your care processes, once you have come to the point where you manage cost of care for your patients really well, there's only so much you can improve going on. And that, that makes it more challenging for cost-effective providers to earn shared savings in arrangements like that. And the third one included is the PMPM trend comparison to a control group or the market. And in this, and this one actually has downsides of both previous methodologies. You may not know your exact cost targets until that performance period is over. And also providers that already have the low cost of care. They will be at a disadvantage when compared to providers with currently high cost of care when it comes to the trend of lowering the cost of care throughout the performance period. All right. What we often see in Category 3 APMs is that whereas cost performance typically comes first, there's often, most of the time, there is a certain quality gate. That what we refer to quality gate is a set of quality measures and targets that provider needs to achieve to really qualify for the shared savings that may be generated. And one of the reasons to have a quality gate that you may here see as referred to in this industry is that to make sure the provider doesn't reduce the cost of care by denying care to members, to make sure that members still receive all necessary screenings, receive comprehensive primary care. And sometimes you even see some utilization measures used as quality gate. So we often see a set of quality measures in a contract that we need to track and make sure that we perform well on to to actually be able to access any of the shared settings that may be generated. And there's some challenges around managing quality performance of a risk portfolio. One of the challenges is that measure definitions may vary from contract to contract, even if we're talking about this essentially the same measure, the same metric. And I used here as an example, those actually measures from actual contracts that I pulled out. So there's a common measure that you see actually across all lines of business, and that has to do with comprehensive diabetes care, and that's HbA1c for control. Sometimes we see measured as greater than 9, lower measure result is better. Sometimes it's, you can see that it's less than 9 and high measure result is better. Sometimes it's less than 8, sometimes it's less than 7. And whereas measure itself on its own makes sense, when you try to put together kind of a snapshot of how you're doing across portfolio, it becomes tricky for providers to monitor their performance, and really it becomes cumbersome, let's say that, to manage and to really monitor effectively how you're doing on the set of measures. It's really, you end up with a list of measures going from, say, 10 measures to 45. And 45 measures, when you have 45 measures as a priorities, you know that probably none of them are going to be a priority. So that's a challenge. Also, contractual targets for the same measure may vary greatly across portfolio. And if we take, cervical cancer screening, sometimes it's 65, 72, 78, 80% may be a target depending on which contract you're looking at. At the same time, it's not uncommon for provider organizations to have their internal targets for the same, for a set of priority quality measures. And that, those measures would also have certain targets associated with them that all medical groups within provider organization will be working towards. And it's not, and that measure target may be even different from what we have in the contracts. And if it's somewhere, say, in the middle of the road in terms of the values, the measure targets, you may find yourself in a situation where you have met the organizational target for the measure. Say if you're aiming for 70th percentile. But it won't necessarily mean that you met the measure that you have in the contract. And that creates some disbalance and some challenges on how provider groups may want to approach measuring and tracking and improving the cost of quality performance. So also for many measures, claims that are alone are not enough to accurately represent providers' performance. So there are a lot of measures that will, for which providers' performance will come through claims pretty accurately through administrative measures. For example, the fact that blood sugar was tested will typically come through claims. But if the contract performance is measured based on the value of HbA1c control, that is something that the payer will not see in the contract through claims data. And that's when it becomes very important to for the payer to have accurate, payer needs to have accurate data on our product performance to be able to assess how we're doing on the contract, on the quality component of the contract. And just in my recent history, we were looking at contract, and our score was just based on claims was 23% or 100% on quality. But once we did the chart scrubbing and attestation, it went up to 95. So it's a dramatic swing just based on payers not always having access to providers' EMR supplemental data. That could be providing supplemental data, providing EMR extract would be one way to deliver the data to the payer. But it's also very important for payer to have accurate data to be able to accurately assess how much incentive may be earned by a provider. There's some challenges that I alluded to earlier that have to do with managing risk contract performance based on the reporting rate of payers. And a significant time lag between performance and reporting period is one of them. Also, incomplete or insufficient data in detail on our cost performance that peer, the reports that are created by peers and maybe given to a provider on a monthly or quarterly or sometimes annual basis, they may not have enough detail for you to effectively manage cost of care. For example, you may see in the report that it says imaging utilization is a cost driver. So that's good information to know, but doesn't really give you anything actionable because imaging could be many things. But if you knew that, say if it's an MRI overuse in a particular clinic or for a particular condition or by a particular group of provider, that could be something that you could work with to address the cost of care driver. And not always you get that level of detail from the reports created by peers. Now also, reports that created by peers often come, well, most of the time they come in very different formats, and as I said, great detailed variability, and peers use different categories. Peers may be using maybe even lumping providers, in different groups when reporting back to you your performance, and which makes it rather challenging to compare how you're doing across a portfolio when you compare contract performance to another contract performance. And also, there's great variability in reporting flexibility and how willing and how really how willing peers may be or able to modify their reports to fit your needs, to be more effective and efficient in managing cost and quality performance. And, the challenges that I just described, they really apply to really any provider organization, but there are some challenges, some added challenges of managing this portfolio in a large organization. And one of them is that once you start working with multiple regions, you'll see that, well, regions, first of all, regions can be very complex in their structure. Often regions are comprised of multiple service areas that, depending on how they came together to be one organization, may or may not be clinically integrated, which can be challenging, especially if you pull those service areas in one contract. And also, each service area also have the clinics, they may have different structure within the service area in terms of continuum of care access that they provide. And also regions may be in very different places on the spectrum of APMs. Some regions may be very advanced, some regions may be just exploring, starting to explore the alternative payment models. Also, regions may be very different and resources available to them. They may have different, different organization structure, different ways to approach care management, sometimes patient outreach, quality improvement. Also, the regions may be using different ways to track their performance in value-based care space. You may have regions that have started exploring value-based care arrangements separately, not necessarily in a systematic manner, and they would have developed different tracking systems for the value-based care participation and performance. Also, with that, they may have different approaches to estimating the value of contracts. Well, in general, there may be different approaches to estimating the value and the incentive of a contract, but it's amplified in a large organization. And also, with a large organization, you will need to have an ability to report the performance of a portfolio at multiple different levels. When you talk to clinicians, they really need actionable data. They really need something. Nitty-gritty detail of contract performance to be able to make an improvement. As opposed to when you talk, to leadership, they would probably want a bigger picture of the overall contract portfolio performance. Also, one of the organizational structure complexities is that contracts are often initiated by different teams than the team asked with contract implementation and performance. And that's where it's very important to have that warm handoff from your contracting team to
the region to the team tasked with the performance of the contract. And as well, there needs to be a feedback loop for pay contracting team to be informed on what works well, what does not work well in the existing contract, so that improvements could be made going forward. So a few words on my organization approach to managing value-based care portfolio. As Oda showed you, the population health division structure that we have allows for multiple levels of centralized support in our regions. We have centralized a number of, we really use really balanced centralized approach and regional work when it comes to managing value-based care portfolio. But we do centralization of certain functions allows for sharing best practices, facilitating sharing best practices among regions, resource use optimization, practice standardization, models of care development. And there are a number of things that we do have, services that we provide in a centralized manner to our regions, including care relationship management, strategic financial analysis, dashboards and other tools development, and centralized outreach and care management. And that, the centralized support and strategic, centralized support of our population health division structure is combined with the regional structures that we have in place, typically led by population health councils established in each of the regions and sometimes service areas, depending on the region structure, that they are tasked with oversight of clinical design, utilization management. They are tasked with developing action plans around identified cost drivers and addressing biggest opportunities on cost quality and coding accuracy improvement spaces, as well as they oversee reinvestment in population health initiatives, really making sure that the work continues in that, that we, value this space and we continue improving in that regard. So some information on our approach to patient outreach, and that will go a little bit back to how members are included in our contract. So we do have, as mentioned, central outreach team actually located in Oregon, Portland, that provides outreach to patients in all our regions. And we do have regional outreach teams. Each of the regions has their own outreach team. And it's important to balance the efforts, make sure that we don't outreach to some numbers with the same issue. It's important that we don't step on each other's toes, and that our partnership between the central outreach team and regional outreach team is as effective and efficient as it can be. So there are some approaches that we use to determine which outreach team will be doing outreach to what members, to what populations. And some of the things that we have considered was that when we are talking about outreach to members that have been established with a provider group and just have not been seen this year, or just have been seen, but perhaps they still have some of the quality gaps open. This is something, since it's an established patient, this is something that this type of outreach could be done by our central outreach team, because we know how to reach patients. Our central outreach team has scheduling ability, to schedule PCP visit, for example, in any of the regions. And also, we use our central outreach team for outreach for measures that are standard across the organization. As many organizations, we have a set of measures that are priority for organization, and when it comes to outreach for those measures, we often, this is something our central outreach team does. And as well as the regional outreach team, for contracts where we have, special contracts where we have members are assigned to us, like Medicaid contracts, we have out-assigned membership when member did not necessarily choose the provider, but was assigned to a provider in the general geographic area where the patient resides. So when we don't have an established connection to the patient, we feel this is something that's this type of outreach is more appropriate to do for local teams because they will be working on building that connection. Sometimes it takes a lot of time to even track the applications if we don't have accurate contact information for that member. And also, there's, each of the regions may have priority policy measures that are specific to that region and specific to the cost of care and quality of care drivers in that region that may be chosen selected by the region in addition to the measures standard across the organization. So that's a really, really high level on how we tend to separate which outreach team does which work. But the teams collaborate a lot. It's not something that's just said and done as a plan of work. For a particular measure, especially if, say, a regional outreach team does not have enough resources to do an outreach for, even the region-specific measure, they will work together with central outreach team to make sure that they have that product. And some other work that is happening in the value-based care space when it comes to improving our, continue improving our performance in value-based care arrangement is we're working to align quality measures and targets across contracts when we can do that. Of course, we will never be able to have the same set of targets in a Medicare Advantage contract and Medicaid and commercial because they're just different populations with different needs. But at least to remove the definition variability for same measure, that would already be a great step. Standardizing the format and cadence of the data exchange with payers, and that has to do with the reports that we get from payers, claims data and eligibility data, and the data that we provide to payers to make sure that they have accurate information on our performance. We're also working to, working to provide performance reports at service area level. When you have a contract that includes a number of service area levels, you can often get better reports at the contract level. So, which is, again, good information to have at the high level for the leadership, but it's not necessarily actionable when you have service areas that are not clinically integrated. So, to be able to improve performance, you really need to have as much detail as you can. And just having a performance report at the contract level is not necessarily helpful for that. Also, we continue, our work to facilitate as much collaboration between regions that we have, and to ensure that they share their best practices. As you saw, our regions in very different places on the spectrum of APMs, and there's some things that one region could learn from another. And also continuing developing infrastructure to account for value-based care revenues in a consistent manner that supports investment in population health. And I think that's it for my presentation. Any questions? Oh, we can actually take questions for later if you like.
If you have any questions now, they're going to switch out mics, so we can always ask some questions if you did. Go back to so this. Do we have a question?
Just a quick one. I know the payers are very excited about, value-based because prevention is going to, lower costs. So what is the big motivation for the providers to switch to value-based? Because the more revenue they get. So for them, is that just a reaction to what payers want and trying to come up with or is it something that they see that helps their philosophy?
I'm not a clinician, but from my work with clinicians, I work with a lot of very passionate providers, and you can actually answer that as a provider, but this is really something, this is the right thing to do for the patient. It's the whole personal care. It's building a relationship with the patient to make sure that their needs are met, to not, necessarily what we have on, not based on what we have on our agenda, but what the patient has on their agenda for their well-being. And I've seen a lot of, most providers that do believe that that's the right thing to do. But do you want to ask for that?
Yeah, thanks. I wanted to go back to the slide. So I want to answer your question here, but also as we move from left to right here, so this old model on the left really is focused on disease and number of visits. The revenue cycle is very quick. How many patients did I see that day? What are our collections? what am I gonna get in return? And I'm gonna be able to budget for that. And my value as a clinician is how popular am I? How full is my clinic? My value on the right is how engaged are my patients, how deep is my team, and how healthy are my patients. I may not actually need to see a patient in the clinic to achieve that. And what we haven't done is align the physician compensation or provider compensation with what we're doing here. This is hard. I mean, this is not easy work, but as we move, we're stuck in the middle somewhere, right? I still need to be really busy in the clinic, but I also need to try to figure out how to make my patients engaged and healthy. And what we need is a really lean team on the left. You just need a lot of providers, a lot of exam rooms, and some MAs. Some people to schedule and answer the phones. What I need on the right in this green category 4 is a really deep team. I need expensive providers, like nurses and pharmacists and other people that are not billing fee for service, but are improving the health of my population and engagement in my community. That is a huge resource investment that you don't immediately see because health is long-term. I don't see when we talk about medical cost and quality, it is all about imaging and drugs, right? It is Truvada and Humira, and it is MRIs. Like, I know this, we all know this. We need to change that conversation, though, to say, is it appropriate Truvada use, right? I am preventing hospitalization from immunocompromised states in AIDS if I appropriately give PrEP to everybody and then Truvada and keep my HIV viral loads at 0, right? That's appropriate use of an expensive drug to prevent hospitalization. The problem is that our hospitalizations and our MRIs and all of that has been revenue generating for so long, we have to shift. And we're caught in the middle right now. And I think that primary care is the base of what, and so I'm a primary care physician, value-based care and population health, the base of that is primary care. And at OHSU, this is really tough because we have really been a pyramid in the other direction. We have been a large academic health system with a lot of high-level specialists that do a really good job at ordering expensive drugs and expensive imaging and filling our ICU beds and filling our ORs. Now we got to keep them out of the hospital. How do we change that conversation and be financially viable in the interim is hard. I don't have the magic answer, but I think this is like the foundation that Sophia sort of gave of why value-based care, how we're going to actually move to that. Nobody has the perfect answers or else we would all be doing it, but it's really changing this conversation and changing it together. Because what we need is, we need what we can do well at a primary care and population health level to feed into the contracts we're signing, right? Otherwise, we're not going to be successful. Which is the dog, which is the tail, and who's wagging who, right? What we've done is react a lot to contracts that we sign. That's not really a successful strategy for the future, I don't think. I'm going to quickly try to talk through a couple of things. So who are we, kind of what are we doing at OHSU, and then a little bit where should we go from here, right? So this is just a quick quote from John Hunter. OHSU Health is the only system in Oregon that really is trying to connect the breakthroughs of an academic health center with some of the convenience of community care. And is really built around ensuring that seamless access to care as the standard. This is a footprint of where we're at in terms of primary care. So thinking about OHSU Health as not just OHSU on the Hill, but as East Portland and Adventist, and as Hillsborough and the Tuolumne, a sort of number of providers, hospitals, right? So there's 4 hospitals now, Dornbecker, OHSU, Tuolumne, and Adventist. And then there's a whole mess of neighborhood clinics. And what we need to do is not think of each clinic as a silo and each hospital as a silo. It's got to be an integrated system that we just are starting to play in that realm where, you know, the Providence system has, in Kaiser, it has been much more integrated as a true delivery system over time. Quick map of just dots on the map, right? So this is the Portland metro area. This is just a representation of those clinics that I listed. This is sort of the OHSU Primary Care Live, kind of looking at fiscal year 18 and 19 in terms of, this is the OHSU proper, not including the Hillsborough or the East Portland and towards Adventist. We have 10 primary care clinics that we are trying to kind of going back to the question, what do you do with internal medicine? Well, what do you do with family medicine, internal medicine, and pediatrics? And how do you meld them together? That is our 10 clinics there and our total lives, our total clinical visits. And then I added an average continuity rate. I didn't have it for FY18 easily. But what we know is that primary care is relationship based, right? It's engagement of our patients in order to achieve health. We have to engage them with continuous relationships. We know that we can lower the cost of care if we have engaged providers and if we have higher continuity rates. And so keeping an eye on that is really important. This is just quick, I know you cannot read the small print, that is totally appropriate. This is just kind of, we have created an Office of Primary Care and Population Health here, and this is a rough infrastructure, right? And so up on the upper left, Chief Primary Care and Population Health Officer, that's the role I'm playing as an interim right now. And then we have this sort of council and operations of a cabinet, and then engagement of all of our medical directors and practice managers. We have lots of subgroups. They're all forming and norming right now. And what we're trying to do is really elevate some of our leaders that we can identify into some of these leadership roles so that we can harness their great ideas in the infrastructure around so that we can get engagement from each of the clinics. Quickly, our current programs across those 10 clinics is CPC Plus, primary care, patient-centered primary care medical home, pay-for-performance Medicaid programs, and then we have one FQHC and one rural health center. And so that is trying to wrap all of these around to one, I think that you made a great point in talking about what providers really want is to be payer agnostic in our delivery of care. It is very difficult for us to sort of think about, I'm gonna, my cervical cancer screening rate target is 68% for this patient and 72% for this patient. The answer is really do the right thing for all of the patients. And we need to do that on the back end, but we need to not put that noise in front of clinicians to be successful. We need to choose a metric that makes sense and hold them all accountable to that metric and then work it out when we have to deal with our different contracts. Because it gets too much. Why does value-based care benefit our patients? I think that we've kind of talked about this, right? Convenience, the right place, the right time, improved health outcomes, accountability for clinicians and care teams. Not just how many patients can you see, but actually how healthy are your patients? How engaged are your patients? We need some transparency around price and quality for patients, and then overall partnership and lower costs of care. Really for our providers and our care teams, there are a lot of benefits as well. Flexibility to innovate and deliver care in different ways, right? My chart messages and video visits or e-visits. We need some proactive funding to help build the depth of those teams, and that's what we get with some of the wraparound payments as well as some of the CPC Plus payments. We need alignment and then data. You guys know the importance of data. Clinicians have different data in their head much of the time, and what we need to do is share that same common language. The problem is we're stuck in the middle, and it's really hard right now, and we have to sort of lead a path forward in this. I think there's some opportunities from the patient perspective, right? We know that it's challenging to really communicate enhanced value to individual patients. Some of the specifics that we're really struggling with right now. So if I want to do an e-consult or an imaging guideline, so I know that if I have a complex question that I think that one of my ear, nose, and throat specialty colleagues can answer, I can do this e-consult. The patient's chart goes to them, ask a specific clinical question, and then I can then deliver that answer back to my patient. The patient maintains their relationship with me, my clinic, and my team, and has the expertise of our specialists. How do we then translate that as value to the patient instead of, no, in a managed care world, I'm going to be the gatekeeper and I'm going to say you can't see that patient, right? That's how it's sometimes translated. Furthermore, how do we actually charge patients for this with telling them it's actually less money for you to take this small charge than it is for the copay of going to see one of our specialists and the time off of work and the parking fee and whatever else is involved there. That's hard. We're struggling with how to do that now. Some of the imaging guidelines feel similar, right? imaging for back pain. How do we take this and say, no, I'm sorry, you don't need an MRI, what you need is physical therapy. I know that your plan may or may not cover physical therapy well, but that is actually the evidence-based way to do it. Instead, I look like a barrier, and then I'm trying to give inferior care because I'm trying to lower the total cost of care. How do we change that language to say, no, actually, I'm enhancing your value. This is evidence-based medicine, and this is what you actually need. These are hard conversations, and not only do we have to convince each other in the room, but all of the clinicians and all of our patients. And I think that there's then, you know, I think you hit on this a little bit in terms of potential for confusion with multiple resources, right? Transitions of care are vulnerable times for our patients. When they transition from primary care to specialty care, in and out of the hospital, in and out of skilled facilities. When you have central, regional, and even clinic-based or local resources, which care manager touches them? Then when you have somebody with multiple chronic diseases, heart failure, diabetes, et cetera, is it the central diabetes resource person? Is it your clinic triage nurse? Is it, I mean, when you start to come at patients with multiple different care managers, they don't know who to believe, and they're not always aligned. And so as we set up these systems, we really need to keep in mind what is what should be local, what should be regional, and what should be central. And the answer may not be the same for us as it is for Providence, as it is for Kaiser. The resources at different levels may be different, the patient populations may be different, and it may not be the same in each clinic. From the provider perspective, this one's a little longer because I have a lot of opinions about this, about sort of challenges. Compensation has not caught up. And this is something that's hard to fix, right? It just hasn't caught up with the payment models and the incentives and the technology, right? This idea of pajama time, of time spent charting, time responding to my chart messages, time on those non-billable things, non-WRVU producing kind of things. I have a lens of roughly how many RVUs I have to make to achieve X, Y, and Z. How to achieve health is really hard. I need my teams, and what we've done is we compensate providers only. My patients' engagement in their diabetes and engagement with a care management, yeah, sure, is somewhat dependent on me, but it's not completely in my control. And yet we compensate providers and put all of the quality metrics on them and their payment, but yet we don't hold our nurses to the same accountability and things like that. So we need to think about how to compensate our teams. We need to think about how to build highly effective teams in ways that are rewarding. Money is a driver for some, but not for all. And so I just sort of introduced that idea that money as compensation doesn't always drive behavior change for everyone. Specifically for primary care, I mean, I think we all went into primary care with a slightly different mission overall, because it's not like our salaries are the highest. Value-based care programs are really administratively burdensome to manage, and we have to be mindful of that. There's a lot of duplication and disjointed care that we really have to think through. What are the health plan resources? What are the local resources? We're still operating in silos. The primary care home versus the just in ambulatory in general versus inpatient, right? It's got to be integrated for us to be successful. And then from a provider standpoint, there's just too much noise, right? In one visit, what can I address? And sort of the in-reach and the outreach becomes important, right? If I have to address the chief complaints, the HCC codes, quality, preventive care gaps, and by the way, do Medicare wellness visits in 20 minutes, I'm not going to be successful. So you lose engagement. And so you need to choose wisely of what your providers do, what the rest of your team can do, and how you can develop those systems to be successful. The quick and dirty answer to sort of, I'm not quite exactly sure what your question in terms of what do you do with internal medicine, but in general, what do you do with people who want to dabble in primary care but don't really want to be listed as the PCP? You ask them to do the Medicare wellness visits. The true people who want to do the primary care will do those. That's about it, because they are incredibly cumbersome, but potentially valuable if you do it the right way with the right team. So this is kind of a quick and dirty of sort of what we're doing. We've got to get together and align, not just amongst ourselves in primary care versus specialty care, but really the payer strategy with all the contracting, et cetera. This is going to be culture change, right? In terms of sort of me and my patient coming to me and scheduling with me, and then I have all of these things and the patient kind of goes many different ways. The patient's in the middle. We've got to surround ourselves with the resources to help the single patient, and we've got to work together in a way that we've never really done before. And this is going to be hard work. So data, right? Inherently, physicians are competitive. We all know this. We've all kind of gotten there. And so we are, or should be, data-driven. It's just what data, and we argue about the data all the time. We're always going to do that, right? So the other thing is that some of us have more experience with data and interpreting the data than others. And so what we have to do is get it to be simple and put it in front of them. This is a screenshot of my data. I will own it. My hemoglobin A1C pore control is in red right now, right? So going to what quality metrics do you choose? What are the definitions of the metrics, and how do you display them? Just starting this week, we have 92 primary care we care about for different contracts and payers and things like that. If I showed 92 to 300 providers that have no idea what I'm talking about, they're going to just turn their brains off. They're not going to see it. So we chose 5, right? Are they the right 5? I don't know. They're the 5 for this year. That's all, right? And there are top 5, right? Diabetes is important, flu is important, depression is important, et cetera. And so we're going to kind of get some data out there. This is going to show up on there as soon as they log into their EMR. It's going to show up in front of them, and we're going to start a conversation over the next 3 months. And we're going to keep iterating. We found some big problems, like we were choosing flu on the background from last year. We need to choose it from this year, right? But all of these things are going to be iterative, and we want people to engage. We want them to ask questions, and we're going to learn who the early adopters and early engagers are, because those are going to be the people that are actually going to send us all of the questions and concerns and comments, and then we're going to try to utilize them and harness some of their energy into teaching others. But getting 5 in front of people, even though I know that there's 92 that matter, we've just got to start somewhere, and we've got to start to change this conversation.
Is this, was this dashboard developed in-house or using payer data? How are you populating this?
It's a good question. This has been probably about a year of arguing back and forth about what data to compile to do. So some of these are CCO metric data, some of this is NQF in terms of what the metrics are. This is data from our patients, and going back to attribution, how are they attributed? One of the family medicine, internal medicine, pediatric, whoever the PCP field is, an active patient is defined as someone who has been seen once in the last 36 months in primary care. That's our baseline. Is that the right baseline? We have a lot of thoughts about that. Should it be 18 months, 24 months, 12 months, 36 months? I don't know. And the numbers are going to change, right? We're starting somewhere, but it's about the PCP field in our EHR, and that motivates us to keep that accurate as one of our attribution.
So this is EHR data.
This is EHR data. It's not necessarily claims data, though claims data can feed into a different dashboard that we can get to. So sort of where do we go next? We're forming this IDS, the Integrated Delivery System, right? And taking risk for existing 40,000 Medicaid lives starting January 1st. We're thinking about a potential participation in a Medicare ACO, a shared savings model. More bundled payments are coming, and then whatever primary care first is going to bring after CPC Plus. We're all anxiously awaiting this. And so just as a reminder, primary care first, CMS program, January 2020 start date, 26 states, 5-year program. And really this is gonna change the game about how I need to document, is how I think about it. I'm gonna get $50, whether I document a lot of review systems or not, is how I think about it. But I'm gonna get $50. I need to do a lot of work for $50 as an office visit, which means I need to put some resources into the outreach and to what I'm doing with my team. And I think that we have kind of 3 big opportunities. One is an opportunity to really scale our care delivery model to really provide high quality care for more Oregonians. We want to continue to partner with payers to really better align and coordinate the care for our patients. And then really we need to align our contracts. In my ideal world, what we would do is figure out what we actually care about in primary care population health across the medical neighborhood with our specialties, figure out what we're kind of doing right a little bit, so not perfect metrics, but a decent metric, figure out where everybody is aligned and incented to go, and then have our payer strategy folks actually sign the contracts with those metrics in mind, so that we really can align and move the needle forward, versus what happens now is just a much more disjointed, we feel reactive from a clinician standpoint. This is in the next decade, hopefully this will happen in terms of the alignment, but it's got to start with a conversation. That's all I have. I wanted to kind of catch us up and allow for questions, comments. Come back up. Yeah, of course.
This particular model is only for the OHSU primary care clinics, not for OHSU other, because everybody else started following the same philosophy, OHSU.
So really with the IDS,
Yeah.
we have to figure this out real quickly, right? And so if we're going to be responsible for these 40,000-ish Medicare or Medicaid lives, sure, we have an infrastructure in primary care, but we really need to, we're working really hard to work across our medical neighborhood with all of our specialists as well. And we're gonna play with this whole idea of an attribution list, right? And who are our members? How do we do outreach to those who are not engaged? We know the ones that are engaged, they already have PCPs. I'm less worried about that. We can beef up our infrastructure and how to take care of them well. But that should be what we're already doing. We just need to enhance that a little bit. What we really need to do is figure out who's just using the ER, who's just using immediate care or urgent care, and how do we get them in? Now we have a larger reach in terms of all of the sort of East Portland and the Hillsborough area, and we have more capacity in our east and west side than we do in our metro area. And so we need to engage them in the clinics that they live in, or the communities they live in, and the primary care that they have opportunity to access.
This is how you market yourself to payers also, right? Like, in terms of you come to us, you're getting the total.
So that, I think that's how to think about it long term, is figure out what you're really good at, and then figure out what your vision and your infrastructure is, because then I can sell it, right? Now we're in the forming part, but that's exactly where I would like us to go. It's just gonna take some time.
And also the other thought I had is that everybody needs to be vertically integrated, because if you are just here and a lot of stuff is going on here, that's affecting this, and when you're not here, then how do your hospital is not as full because of prevention, then what are you doing? You're not integrated.
Yeah, these are hard conversations to have, right? Especially in a really heavily matrixed organization like OHSU, where there's many different incentives in different departments and divisions. Starting that conversation is what we're doing right now. We're not going to hit the mark on January 1st by any means. We're going to have a huge growth curve, but I think that we're committed. I know that we're committed to doing the right thing. And what that means is that we're going to have to start to align, and some of it is following the money, right? And some of it is just really going to be saying, this is actually the total cost of care, and figuring out where our outliers are, and then figuring out if they're appropriate outliers, right? Everyone is a special snowflake in terms of, physicians and clinicians, and we all say we have the most complex patients. Well, show me it. What are your HCC codes, right? What are your risk-adjusted scores? And then what is your utilization? And is it appropriate for your risk scores? Fine. I'm not gonna continue to have this conversation and argument because it's appropriate. But if you really truly have outliers, that's when we need to sort of look through what does that mean in terms of who the outliers are and what we need to do to change behavior.
Hi, I'm Jim McCollum of Auto Health Plans. Attribution seems to be one of the biggest talking points in healthcare nowadays in any program, whether it's CPC Plus, high value. Do you support then having payer conversations, and attribution is different across payers. So then would you support having attribution methodology in your specific contracts or value-based arrangements?
Do you want me to answer?
You can start.
I have, so from a population health lens, I want a clear and easy and inclusive attribution, which is why we thought about PCP last 36 months. Are you a new patient or not, right? If you look at some of the CCO or IDS metrics, or is it looking back 24 months? And then we talk about some of the complexities of, is it based on PCP? There was a time when it may have, Oregon Health Authority may have said, oh, it's going to be based on specialty mental health. You know, where's your pain point is what that's following basically. Coming back to primary care as the foundation, I'm responsible for this care. If I've seen this patient once, but they've seen cardiology 17 times, still my patient, and I'm still going to try to engage. And so I would favor a much more broad, inclusive, and realize I'm not going to succeed for everybody. Versus I think the tendency sometimes is to get super narrow so we can succeed, and then we lose that long vision of health and where we need to engage our patients. And it's okay to not be at, and we're never going to be at 100%. I think it's just sort of setting the right expectation.
And just piggyback on that a little bit, you know, from contract management standpoint, what I want to know is who are the members in the contract. Either that's and not after the, you know, performance period has ended. Because if I know that I can literally track my performance in a particular, for a particular population, I can develop tools and dashboards that will help providers monitor their performance and manage the trend that they have seen. And that, you know, maybe achieve, you know, having that visibility in that kind of membership, knowing who your patients are, maybe achieve in multiple ways. And I personally am not sure what the right answer is in terms of what your particular attribution methodology or assignment methodology would need to be used. You know, if I could pick one for the whole industry, I think I would have to think really hard on that one. And I don't have an answer for you off the top of my head, but whatever will give me that visibility with the membership of my contract, I think I would go for that one.
I want to say one thing about the different metrics that, you know, kind of you explained in terms of the A1C less than 8, less than 7, less than 9. From a provider standpoint, it's just about diabetes management, right? And so I think you'll get pushback from a provider if the measure starts to get too low, because now we can actually talk about the evidence and say, actually, if you push people too low, there may be more complications from hypoglycemia, and it's not in their best outcome, especially for certain older populations. But less than 8 or less than 9, my behavior really doesn't change. It's still uncontrolled diabetes. I still need to throw resources at that patient and understand what is the barrier. And so on some level, yeah, we need to know for reporting purposes for different contracts, but from a clinical standpoint, it's still about diabetes, hypertension, and screening as the sort of big ones that we all need to kind of focus on.
So just one more question, sorry.
Yeah.
Because I know that Providence at least they're trying to get a system in place to be able to update the payers with their current provider rosters. How's, you know, with that matrix organization, lots and lots of primary care clinics, probably, you know, turnover, you know, happening. How are you informing the payers of what's going on in your clinics?
It's hard. And so part of this is really looking at, we're doing a lot of work on access and capacity management in preparation for January 1st. And a lot of that baseline work is around things like rosters of who's actually accepting new patients in our clinics, how is that going to be updated, who's going to be responsible, and it goes to not just the existing, but what do we do when someone retires or leaves? What is the onboarding of new providers, and what are all those loops that need closure, and how do we run lists of panels of patients and remove the PCP and coming to agreement amongst the different primary care specialties for that? Or these are literally agenda topics in the next 2 months that we have, because you're asking the right questions. it's the right conversation to be having right now, and I don't know that it has to be the same for every organization. But it needs to happen, and it needs to be a robust process. This is sort of an example of what we need people to, I need people to help me do this. You cannot let it sort of remain to me as the primary care provider, because I will not do it. And then everybody will be mad when the attribution is not right.
Any other questions? All right, well, thank you guys so much. Just a reminder to fill out your surveys. We'll find a QR code at the bottom of the agenda. Also, lunch will be served next door, earlier this morning at noon. For those that are going to be in the finance problem solving meeting, that's going to be in this room also at noon. So go grab your lunch and come back here. And then after all of that, at 1 o'clock, we'll be discussing pricing transparency next door. Thank you, everybody.
Thank you.
No, it's true. No, wait.